Good afternoon, folks. Today's topic A deals with ADHD and chronic pain care. Okay, so I've got a full policy brief for you on this subject. So here we go with today's show. Below is a full polished executive ready policy brief on integrating ADHD and chronic pain care across health systems. It is structured for legislative, payer, and health systems leadership audiences, and written in the narrative rich, evidence forward style you prefer. Guided links are embedded throughout so you can instantly expand any section. Okay, integrating ADHD screening and chronic pain care across health systems. Prepared for Pennsylvania health system leaders, payers, and legislative stockholders. Attention deficit hyperactivity disorder, ADHD, and chronic pain frequently co-occur, driven by shared neurobiological, behavioral, and genetic mechanisms. Yet health systems continue to treat them as separate conditions. This fragmentation leads to delayed diagnosis, ineffective treatment plans, higher opioid use, exposure, and avoidable disability. Integrating ADHD screening into chronic pain pathways and chronic pain assessment into ADHD care is a low cost, high impact strategy that improves functional outcomes, reduces unnecessary utilization, and advances health equity across Pennsylvania. This brief outlines the evidence, the system gaps, and policy actions needed to modernize care. Background: why ADHD and chronic pain travel together. ADHD and chronic pain share overlapping mechanisms that make each condition amplify the other. Neurobiological overlap. Dysregulated dopamine and non norepinephrine systems weaken, descending pain inhibition, okay, central sensitization. heightened reactivity in pain processing circuits, increasing pain sensitivity. Executive function challenges, difficulty with pacing, planning, and task uh, persistence. Under undermines pain. It's undermines pain self-management, psychiatric comorbidity, anxiety, depression, sleep disruption, and substance use, vulnerability, intensify pain severity, genetic coalition. Polygenetic studies show shared risk across ADHD, migraine, chronic widespread pain, and mood disorders. Adults with ADHD experience 2 to 3 times higher rates of chronic pain, and chronic pain patients show elevated rates of undiagnosed ADHD. Despite this, the two conditions move through the health system on paralleled tracks. Problem statement: high prevalence, low recognition. ADHD is underdiagnosed in adults, especially women, older adults, and individuals with chronic medical conditions. Pain clinics rarely screen for ADHD. ADHD clinics rarely assess pain. Symptoms such as restlessness, sleep disruption, and emotional dysregulation are often misinterpreted to mood disorders or medication side effects. Fragmented care pathways. Pain medicine, psychiatry, primary care, and physical therapy operate in solos. No shared protocols exist for identifying or managing ADHD pain overlap. Patients cycle through multiple specialists without coordinated treatment plans. System level consequences: increased emergency department utilization, higher rates of polypharmacy and opioid exposure, low functional recovery after injury or surgery. Greater disability claims and workforce loss, raising costs to Medicaid, Medicare, and commercial payers. Why integration matters now: clinical impact. Treating ADHD improves consistency with physical therapy, emotional regulation, pacing, and activity planning, catastrophizing and pain-related anxiety, even when pain intensity does not dramatically change functional outcomes. Improve, which is the primary driver of cost and disability. Economic impact. Integrated care reduces unnecessary imaging and diagnostic testing. Repeated specialist visits, long-term opioid prescribing, disability related costs to employers and payers, avoidable avoidable emergency department utilization, especially in rural regions like northwestern Pennsylvania. Equity impact. Women, older adults, and individuals with chronic medical conditions. Groups. Overrepresented in chronic pain. Populations are systematically underdiagnosed with ADHD. Integration directly addresses this inequity. Policy recommendations. 1. By directional screening. Implement ADHD screening in chronic pain clinics using validated tools. Incorporate pain assessment into ADHD evaluations, including multi-site pain, sleep disruption, and functional impairment. Embed screening tools into EHR workflows to ensure consistency and reduce clinician burden. 2. Cross-disciplinary clinical pathways. Standardized referral pathways linking primary care, psychiatry, pain medicine, and physical therapy. Embedded ADHD informed strategies into pain rehabilitation, structured pacing, and executive function supports behavioral activation. Expand co-related or virtual consults models for rural and underserved regions. Workforce training and competencies. Develop CME models on ADHD pain overlap for pain specialists, psychiatrists, and primary care clinicians. Train behavioral health providers in pain-focused CBT adapted for ADHD's executive function profile. Support nurse practitioners and physician assistants in integrated assessment roles. Reimbursement alignment, incentivize screening through quality matrix and value-based contracts, reimburse collaborative care models that include ADHD management within pain programs. Support telehealth for follow-up, ADHD, and pain visits. Research and demonstration projects. Launch state-funded pilot programs testing ADHD pain integration and health systems. Prioritize research on stimulant and non-stimulant effects on pain outcomes, functional recovery, and opioid reduction. Evaluate cost savings from reduced emergency department visits, imaging, and disability claims. Implementation roadmap. Phase 1, 0 to 6 months. Foundation. Adopt standardized screening tools. Update EHR templates and workflows. Launch clinician education models. Identify pilot state or sites in rural and urban regions. Phase 2, 6 to 18 months. Integration. Establish disciplinary referral pathways. Embed behavioral health support in pain clinics. Begin data collection on screening rates, treatment uptake, and functional outcomes. Implement telehealth follow-up models. Phase 3, 18 to 36 months. Evaluation and scale. Analyze utilization, opioid prescribing, and functional outcomes. Expand successful models statewide. Integrate findings into Medicaid and commercial payers contracts. Publish outcomes to petition Pennsylvania as a national leader. Key messages for policymakers. ADHD is modifiable. ADHD is a modifiable risk factor for chronic pain disability. Integrate screenings is low cost, high yield, and immediately implementable.